What we've heard today in many different venues has been about systemic change and how complicated and multifaceted that is. Requires many players, multiple levels. In particular, public health problems are complex for emerging markets, even more so. Once upon a time, I was a world banker 30 plus years ago, and we used to talk about, this was sort of systemic change 1.0, and we would talk about how, but it was kind of sad and much more limited. We talk about silos, that there were things that the World Bank could do, there were things that countries could do, there were things for philanthropy and so on. And there was not this thought that you hear at SOCAP and that you'll hear about in this session, that there's an important role for collaboration and that these silos bleed grain between them, that there are lots of places where there can be that kind of collaboration and it's not so clear that only one entity can work in this area, or even more so, that getting to a real systemic solution requires all of the above. So we are lucky today in this session that was sponsored by an entity called III for GH, which is Impact Investing Initiative for Global Health, who proposed this and wanted to have us talk about these kinds of issues. It's an entity that was promulgated by the G7, how long ago, Steve? Not very long ago. 2 years ago. I first heard about it 1 year ago, and now it's its own session here at SOCAP. And so and we're lucky then to have representatives across that whole range, from multinationals to philanthropic entities to national governments and private sector, participating in solutions in public health, particularly for developing countries. So we're going to start with, you've got titles above us. You can look everybody up in LinkedIn, so we won't spend a lot of time on what our credentials are. But we'll start with, well, let me introduce our people: Steve Davis, Liat Gels, and Scarlett Chen. But we'll jump right into it by having Steve tell us about G7 and what his vision is for the initiative and what its main activities are.
Well, thank you, Eric, and thanks everybody for joining us on this afternoon and holding in there today. First of all, my kind of have multiple hats and see a former student from my teaching at Stanford Business School for many years, as well as I'm at the Gates Foundation working and overseeing all the work they do with other philanthropists, but have had many hats there and come out of the global health space as well and the technology space. But the hat I'm wearing today is as one of the co-chairs of this G7 initiative, and let me just give you just a few seconds on what and why and what we're hoping to accomplish. So this came out of the meetings in Japan when Japan was the head of the G7 and they sort of switch year by year across the countries, and committed to saying, you know, the paramount issues around global health are, in fact, with ODA declining and other challenges in the global health space, and yet there's so much growth and innovation going on in the space as well, is that we needed to have the G7 countries, the 7 richest economies in the world, put their muscle behind it. So they created a communique, which is one of these diplomatic terms for saying a sentence, that they pronounced in Hiroshima a little over a year ago, and in it they committed to do something about this question about how to accelerate more social impact investing into global health. And so I was appointed as one of 3 co-chairs of that, of this effort, and it's housed in the Prime Minister's office in Japan. But it is a global effort working across many countries and many partners. We have, I think there are well over 100 partners, including impact investors around the world, different kinds of advisory services, different kinds of associations that work on impact investing, and trying to consolidate around how do we actually move the needle here. And so we've really come up with 3 things that we're doing, and some of it will touch on some of the work that my colleagues here are doing specifically. But one is really getting a little bit better visibility around this. So and we have heard repeatedly that the lack of understanding of what we mean when we talk about social impact investing in global health, the lack of a lot of good exemplars or good use cases to share the good stories or learn from the not so good stories, and there were a number of other gaps, including the lack of understanding of sort of what do we mean by impact measurement. So we've taken on 3 things. It's a short sprint. It's only the cycle of a G7 initiative is you do it for 2 years and then you hand it to the skip country. So we're hoping Canada will pick this up next year, but we have a 2-year window to get something done, and we are focusing on 3 main things. One is really profiling great use cases and great stories, so actually we can build more confidence in the sector. We understand that there's a lot going on. It's quite confusing. It's not, and it shouldn't be government organized, but there's still a lot of mismatch between what stories are people learning about, where the interesting opportunities are. So trying to profile that more. So we've been doing a lot of different case studies. We're presenting at various conferences, publications, et cetera, on sharing more of the best examples. The second piece that we're working very much on is on measurement. So understanding that in one of the biggest barriers we're seeing in global health, for particularly investment so there's tertiary care, like hospital care in urban cities and lower middle income countries, there's more investable opportunities there. But as you start pushing toward rural care or primary care, harder to find good investable opportunities. But one of the things people are trying to understand is how do you even begin to measure the non-economic return on the social side. So there's actually a very, and this becomes actually investor after investor, fund after fund that we talk to around the world. So this is actually one of the biggest obstacles, is it the lack of, it's not that there's not a social impact measurement. The fact is there's 100 social impact measurements or maybe more, and different models and mechanisms. So one of the work we're trying to do is come up with some sort of working with a working group and a variety of global leaders is a more coherent playbook on how do you actually use these different measurement tools and what's bespoke and what's useful. So hopefully we can advance the field if we can get more clarity. And the third area, which I'm personally very involved in, is working on, ironically, given the whole effort here is to drive more and crowd in more private capital into the space, is actually to go back to the very sponsors of our initiative, the governments, and say, what can governments be doing more or less of to make sure that this gets accelerated. So we're actually working again with a group of consultants and leaders and advisors in an advisory group to look at both countries that are looking to have more capital come inbound. What is it that investors are looking for them to do? What can they be providing in terms of the parts of, what kind of health system issues are they looking for? What kind of capacity they can build for more investable opportunities in those countries, and case studies around that. And then, as important, countries that are hosting the outbound investors. And this is areas, things like, how can we create mechanisms that pool risk around foreign exchange exchange, things like mechanisms like that. The age-old, the ticket size for DFIs are too big to get investments into the smaller funds or organizations. So working on that, we'll be presenting those recommendations in Davos in a few months. So those are the three main things. We're still looking for another initiative to launch and hand off to Canada. But we hope the bottom line is that with this effort, we can heighten the conversation at senior levels of government, support new models for governments to consider to help us inspire and accelerate this work, and finally look toward more specific policy changes that governments might consider at different levels of government in order to again engender more impact investing into global health globally. That's it.
Thanks. And speaking of Canada, and bringing this down to a national player, Liat has been for the last decade at Grand Challenges Canada, and maybe you can start by telling us a bit about what you do there and what your roles have accomplished over these years.
Thank you so much for having me and for inviting me to be part of this panel for III for Global Health. So I'm the Director of Social Finance at Grand Challenges Canada, and what we are an innovation platform that seeks to seed and transition to scale innovations and health innovations primarily in low and middle income countries and in Canada. We're rooted in the philosophy of what we call integrated innovation, so we don't just fund tech innovation in health, but also really looking for social enterprises that are innovating from a business or social standpoint, or all three. And to date, we have funded over 1,700 innovations in 106 countries. Of those, 1,300 are at proof of concept, so 100K to 200K grants over 12 to 24 months. You have a great idea, we'll give you some money to test it and take it from there. The remaining about 400 investments are what we call transition to scale. So those are grants or concessionary risk capital in enterprises really in that valley of death between proof of concept and scale. And our goal is to be that concessionary funder that will help mobilize other funders. We have the luxury to be funded primarily by the Government of Canada and other partners, which allows us to focus really and prioritize on our impact in a meaningful way above any financial return. And so those are some of our biggest goals, to mobilize other capital. I'll stop there.
Don't stop there. I want to ask you a question. You talked about your partners, and I wonder if you can bring that to life a little bit. Who are your important partners? Who are your collaborations with, and how do you work together?
Okay, so there's 100 ways to answer that question. And I'm looking in this room, and we have partners in this room right now. So maybe I'll start there. As an impact first funder, our most important partners are the innovators and the social entrepreneurs we're funding, as I'm sure most people would say. Diana Sierra of B-Girl is sitting right there. We've been working together for over 10 years, not only as funding, but in partnership and trying to support, and she supports us too. And there's a mutual learning that's really important for us because we're always changing our processes and systems as we're learning. I don't think there's a meeting at Grand Challenges Canada that I go to that the term innovator centricity or being innovator centric is not mentioned, because we're funded by the government, there's bureaucracy, we have lengthy processes, and we're always trying to think about how to improve what we do. And so the innovators and the entrepreneurs are obviously our biggest partners to be able to do that. And we have changed and evolved over the last 10 years based on that type of feedback. Whether it be the amount of money, the cap on how much we're providing, the way we invest, and things like that. I think another important partner, I'm going to call people out just because I see you, so I can't help myself. Colleen Connell's going to wave there. She's from Health Finance Coalition, and we've been working together for the last 2 years Health Finance Coalition, together with Africa Invest, a private equity firm in Africa with a 30-year track record, developed Transform Health Fund, which just a couple of weeks ago announced their final close at $111 million to fund African healthcare companies innovating in digital health tech, primary healthcare, and systems supply chain, solutions. And so we were one of the catalytic investors. It's a blended finance structure of the fund. We're one of the first that came in the first close, but we're also working with Health Finance Coalition in a different way, because our board really saw this opportunity for us, again, for this continual learning and to see where there were other gaps beyond the investment in the fund. And so together, we provided a $500,000 grant to develop a deal construction platform with health that Colleen is leading to really bridge this matching gap between social enterprises and the impact investment community in global health, and to see if we could do it in a more efficient, cost-effective way. And that platform is likely evolving in different ways based on those learnings. And if you want to learn about those, you can ask Colleen. And there are many others. I'll just say one more thing. There's Maduro is here in the front too, a wonderful Canadian philanthropic fund. And because we are a concessional catalytic capital provider, we're never going in it alone. And so other funders like Maduro or others that are coming in every transaction looks like that, whether we're providing the grant or risk capital. So those are just some of the examples. And that's why for us, I'll just end with being part of groups like III for Global Health are really important, and coming to SOCAP and all of that in terms of building those relationships to understand where we all fit and to make it a simpler, more efficient process.
Great.
I'll stop
Thank you,
there.
Leah. And thank you to the partners who are here. All right, let's turn to you, Scarlett. You have come to impact investing from investment banking and now are managing an early stage venture capital fund for health tech. So you bring to bear the other part of, or one other part of this ecosystem in the purely private investing space. And so could you tell us, please, about what you're seeing and what the opportunities for you to invest in health tech are?
Sure. So first of all, good afternoon, and thank you very much for all being here today, especially at 5 p.m., the first day of the conference. Thank you all for being here. And Leah, we'd love to be a partner to you in the future as well. So I'm Scarlett Chen, managing partner at Verge Health Tech Fund. We are a VC fund, so we're a venture capital fund that is operating on a global scale that invests only into healthcare technologies. So health tech companies at the very early stage. And we have now, the partners team has invested in 54 different startups from 24 different countries and have impacted more than 70 million lives. We are a fund that actually delivers two bottom lines. So the first is impact. We count the number of lives that we're impacting, and we have a systematic way of measuring our impact. And the second one is financial returns. So we provide non-concessionary capital. We are going for market return as a VC fund. So that's really kind of the thesis behind the fund. And when you asked about kind of, what we do here, at Verge, that is, quite different, I think, from a lot of the other healthcare funds, is that when you think about healthcare, there are mainly three traditional sectors. So there's biotech, there's medtech, and there's services. And for us, we do health tech. And this is really kind of the new kid on the block. It's a relatively new field. And the reason why we do this is actually because we believe in digital, scalable the key is scalable. So scalable technologies that can fundamentally amplify the current healthcare resources. We know that we're facing so many problems right now within healthcare. We're facing a globally aging population. We are facing the disease mix actually shifting into much more NCD, so non-communicable diseases, which are very often chronic by nature. So these are the diabetes, hypertension, mental illness, Alzheimer's, etc. And all these diseases actually need to be cared for. So the current healthcare system is very much sick care focused, which means you get sick and you seek medical help. But healthcare, ironically, we say this all the time. We say within healthcare, where is the health and where is the care within healthcare? So we really go for health plus care. And by health, we want to go into risk detection. We want to go into preventive care. We want to actually go into intervention before you actually get sick. And then in care, it's really in these chronic diseases where we care for the patients on an ongoing basis. So it's not just the moment in time when you go into the hospital. We're talking about healthcare being pervasive, being everywhere, being anytime in any kind of setting. And this is enabled by using technology. And we're sitting at a very interesting intersection these days where we see the power of tech, of internet, of connectivity, of AI actually coming into this space. And we do believe that by investing into technology that doesn't replace, we're not trying to replace anyone here. We don't have enough healthcare resources to start with. We don't have enough doctors, we don't have enough nurses, radiologists. We're trying to take one doctor and turn that doctor into two. We're trying to take one radiologist and turn them into 5. Right, by using technology. So that's the thesis that we believe in. And by investing into scalable technologies, that's also how we can create scalable impact going forward.
Great, thank you, Scarlett. In the impact work that I've done, we don't even call it healthcare. We call it public health. That's our theme that we invest in, and health tech would be a part of that. In the spirit of fleshing these things out to make them more tangible for me and for everyone in the room, can you tell us about a particular investment that's been exciting powerful in an impact sense, and if possible, since people still ask the question, can you do impact investing with a market return? Someplace you've invested where you expect to see good returns and a powerful impact.
Excellent question. I get asked very often, people phrase the question as in, how do you balance financial returns versus impact? And I think that phrasing of the question actually says it all, which is, can you really provide both? Is it even possible, right? And I've said we are non-concessionary capital that creates that impact. And the best examples are actually the examples that we have. The best evidence is just by what kind of returns that we have already produced and the impact that we have produced. And we have many examples of this. But before I go into that, I do want to discuss the logic of why this is actually doable. Right, so within healthcare, we know that we're facing problems of accessibility, affordability, and quality. This is really kind of the key issue that we're trying to address here. And for us at Verge, the impact assessment is actually the first assessment that we do. This is foundational to everything that we do because we believe that impact needs to be integrated into the overall business. It's not something that's separate, right? And not all healthcare is actually impact. So we do that assessment first, and I would actually even say that this impact assessment is actually a very good business assessment. Because if you are addressing these three key issues, access, affordability, and quality, then you are a meaningful and relevant business within healthcare. Because if you're not addressing this, what you're working on might not be large enough or significant enough going forward. So therefore, this assessment actually turns into an excellent business assessment when we are looking at investments. And in addition to that, of course, we look at the usual things. So the three buckets that we look at as investment assessments are, number one, is all about the company, right? So everything concerning the market, the tech, the regulatory pathway, the clinical outcome, the business model, et cetera. So that's all about the company. And then we assess the team. Right, this is a very key metric, especially in early stage investments. And then finally, we look at the deal. So deal meaning, you can have the right company, you can have the right team, but if you don't have the right deal terms, meaning maybe the valuation is too high, maybe they're raising way too much money that they could be wasting this, then it also doesn't work for us. So from all that, from every investment that we go into, we actually ask ourselves, do we see a 10x return? Can we actually see this? Because if we don't see it, we might never even get close to it, right? So we have entirely integrated the impact assessment as part of the investment assessment. So that's how we're looking at this in a very holistic kind of way. So in terms of actual numbers, without giving away too much confidentiality here, but certainly we've done investments that have given back 17 times DPI. DPI is actual distributions that have really impacted millions of individuals. We have done investments where, like for example, in this current fund, one particular investment, which is a technology here in this part of Silicon Valley technology that is ready to go into LMIC. And this one, we're already marked up multiple times. So in terms of IRR, we haven't calculated, but it's definitely north of 100% IRR. So we can see that, right? We can see that going forward. And I think that by creating that track record is going to be what's the most supporting evidence, right, in terms of how this can be done.
Thanks. That's great. A little bit of translation. LMIC, low and middle income countries. IRR, for any uninitiated, is internal rate of return. Just to be sure we're all on the same plane. So thank you for that. And let's turn to the particular areas where you each think you can make a difference. And it's a different sort of question for Steve, but for Steve, for III for global health, what are the sectors in healthcare where you think you can make the biggest differences, or the geographies where you intend to make the biggest differences? What do you, for the next years, what do you think you're going to look back on and think, we really did this great thing?
Well, let's hope we make a little bit of a contribution. I think that's our aspiration. But it's and again, this is not set up to be a long-term play. There's a couple years we can motivate, move the agenda. Hopefully, the next country picks it up. But I do think there are three things that I would focus on. One is for sure the LMIC, the lower middle income country. I've come out of a long history of working both as an academic, as a practitioner, as an investor, and also business and nonprofit in the space. And one thing I think we've learned the hard way over and over in health is that not very many things simply trickle down to to different segments of the market. That particularly as you look at innovations, health innovations that are life-changing in affluent or rich countries that have a lot of capacity but also have different payer and provider models, then to take those very innovations and assume they're just going to find their way into very different mechanisms, very different, where government and insurance is managed differently, and particularly where affordability is at a very, very different level. Those things don't just find themselves there. There's got to be a lot more intention. Some of that intention is to, regulatory, like there's a different regulatory process to get into a lower middle income country. It's a different cultural issue in terms of the adaptive issues about what demand might be in certain settings for certain kinds of tools that are given in the United States or Western Europe and not given in Nigeria or in Cambodia. So have to think through adaptivity, the appropriateness. But also, literally, demand creation is a completely different issue in many of these instances. So I give that all as a bit of a context setting to say that one of the things we're hoping to do with this initiative is to shine a spotlight on those innovations and investments that really work in lower and middle income countries that have sort of certain conditions that are quite different than where we see healthcare in the rich world. And the goal then of III will be very much focused on moving the needle in those regions, trying to shine a spotlight on some of the most interesting investments that have actually moved the needle on health outcomes in those regions, understanding what the construct was around that investment in terms of what the government needed to do, what maybe philanthropy did, or what other kinds of participants in the vehicle or in the investment mechanism did. And so I think shining a spotlight on those things is going to be very critical. And then, as I mentioned earlier, getting clearer on how people can go about looking at investment in lower middle income countries as a potential growth market for them is very critical for us. I mean, taking a kind of steely-eyed economic return, let's say that these are markets in which the middle class is continuing to grow, that despite what's going on in the U.S. and a few other countries, in a lot of markets in the world, the proverbial pyramid that we've talked about for years, the bottom of the pyramid is no longer the bottom of the pyramid. It's sort of a diamond. You have more and more growth happening into the middle class. And that means there's more opportunity for lower middle income consumers to be now consumers of goods and services that these companies can be providing. And that's a great thing for all of us. It means that we can focus philanthropy and aid on more acute cases. We can continue to support that growth through investment mechanisms. So the long story, that's a long-winded way of kind of getting to a big answer, which is, I think, over time, our broader goal, my broader goal, and working with not only the work I do in III, but with investors and also with the Gates Foundation, is to crowd more private capital into health and development, capacity building in lower middle income countries in the world. And I think within the realm of healthcare, I think what we will see is a lot of this will go to technology and digital infrastructure. I'm biased. I come out of that sector. I chaired the WHO's Digital Health Commission, so I've studied this question a lot, but there's no question the accelerant for economic driving growth that will have the biggest return on health outcomes will be related to the digital and AI in the future.
Thanks, Steve. So, Scarlett, could you tell us about, in your investments in health innovations, where are you most optimistic about those that will affect low and middle income country outcomes? Okay. Yeah, I mean, not all your innovations are, they're not all in health, most of yours are, but they're not all for low and middle income countries. So where are you excited about what you're investing in?
Yeah, and I'll build off of what Steve just shared in terms of some tangible examples that we're seeing of innovations in our portfolio that we're excited about, that are really at the intersection of gender lens investing in health and climate and health and things like that. Just a few examples. So we support a company based in Pakistan called Sahat Kahani, which is a telemedicine platform that seeks to connect healthcare services with with people in rural and conflict affected areas. But what's innovative about why we support them is how they're doing that is by tapping into a resource of women doctors who, for social or cultural reasons after medical school, are not practicing and are staying at home. And so these women doctors are now at home providing telemedicine services to families and individuals across Pakistan. And they've worked now with over 7,500 doctors, women doctors in Pakistan that are now part of this, and they're looking to expand to UAE and Saudi Arabia and other countries where you would similarly find this type of untapped pool. And so it's just a really interesting model. There's a Kenyan-based company that folks might be familiar with, Jacaranda, that's developed an AI-enabled platform that seeks to give pregnant women prompts of when to seek health care. And what they're doing is they've overlaid data on weather conditions on their platform because of the linkages on heat stress, on birthing and things like that, to help improve the prompts that women are getting. And I should say, I mentioned Diana before, but I realized I didn't even say what you do. Diana there, B-Girl, is a menstrual health company that has created a really innovative, reusable menstrual health product, really scaling in Mozambique and expanding in Angola and other Western, and now in Western African countries. And, for us, when we invested in a menstrual health company and a few others, I don't even know, I think it was 8-9 years ago, I think it was actually us and Gates Foundation at the table, and there weren't many there. So for us, the exciting pieces are also where others aren't going. We have a huge mental health portfolio, and I know, Scarlett, you have a good example of a mental health company that you're looking at. But funding in mental health, we fund in early childhood education. We incubated, invested in a fund called Cross-Border Impact Ventures, which is funding just focus on women's and children's health technology with dual market strategies. And so that's where we see opportunity for us, where there's a role we can play uniquely, and those are where we're the most excited about. I'll stop there.
That's very inspiring. Thank you, Leah. And so since you've been brought into that conversation, let's ask you, where among your investments do you see prospects for low and middle income country outcomes that are impressive? You can talk about whether they're profitable or not. You talked about some of that before, but the ones that really blow your mind when you think about what could be.
Right. So, for LMIC, we've been tracking our impact within LMIC countries. So take Verge Fund 1, so we're on Fund 2, but to take Fund 1 as an example, so we have counted the number of lives that we have impacted. So that is more than 20 million lives now. And when we look at the breakdown between LMIC versus high-income countries, it is 18.5 million lives in low and middle-income countries, and roughly 1.4, 1.5 million in high-income countries. And when we look at impact, we don't have a simple definition of impact, because we have actually seen impact being generated in various different ways. So there's one camp, which is LMIC companies created for LMIC impact, and that we invest in. That is relatively straightforward, and I have great examples in this camp. We have another camp, which is technology is born in countries like this, in places like this, in Silicon Valley, where there's very strong research, very strong academic centers, and that actually breeds cutting-edge technologies, which can then be commercialized not just in this country. And we say, by the way, we want you to actually do well in this country, but think about the applications that you can have in LMICs. And these founders, because of where they come from, because they're vision-driven founders, we invest in founders. We don't invest in founders who don't care about LMIC. We just simply don't. The intentionality of impact has to be there in the people. And we guide them to LMIC, where we can also help channel their technologies into these countries, help them commercialize, help them get funding, help them get in front of all the various different stakeholders. And that play sometimes is not as obvious to people. So from high-income countries directly into LMIC. But there's fantastic impact actually coming from this way. Now, the last camp, which is very often, doesn't even make sense to people, is actually going the other way around. So from LMIC, going into high-income countries. And we have seen this as well, that have done extremely well. And the reason why we have that is that in these low and middle-income countries, there are innovations which are born out of necessity. And they're being grown and they're being created based on very good tech talent, but they're not here. They're relatively much cheaper labor in these LMIC countries, and there's actually abundance of data, abundance of patients, and it probably takes a fraction of time to get a clinical trial done in another country with a lot of population than, for example, here. And what you come across is actually, in the end, some technology. For example, we have one particular South African technology that has actually then gone into 100+ different countries and has become one of the most dominant players in the US.
Okay,
right?
Scarlett, I'm at the edge of my seat wanting to know what these things are. So, respecting the confidentiality that you have to protect, can you tell us something about an example of this product going particularly from the poor countries back to the rich countries that have changed?
Sure, I can tell you several examples, actually. So one example, Reach 52, Singapore-based company. They have healthcare workers, so they have these rural villagers, right, as healthcare workers who can actually bring the last mile. We're talking about last mile delivery of healthcare services into these rural villages where people simply don't have access to very basic things like health checkups, things like vitamins, for example, right? So they do that, and this company has now impacted more than 6 million lives. And when you look at their impact, it's absolutely fantastic. And this return has actually done quite well for us. And I really want to call out my investor, Dana, who's sitting in the audience from Johnson & Johnson Impact Ventures, who has really supported us in this journey and who is now supporting this particular company as well. Another company, hearing aid company, HearX from South Africa. Now they're all over the globe. You can find their products in this country, actually in various different stores. And they are providing low-cost hearing aids on that. Another example, something that we together invested with Gates Foundation. So this is now going back to my previous career as the head of strategic investments at Prudential Corporation Asia. So we together invested in a company called Halodoc in Indonesia. And this is the largest health tech company in that country. This country has almost 300 million population, the fourth populous country in the world, the most number of islands in the world. And that company now has 26 million MAU, that is monthly active users who are actually using the platform for telemedicine, for drug discovery, for drug delivery, etc. And that investment has done, I believe, quite well for Gates Foundation and Prudential, and the impact is very obvious.
Thanks. So, as I feared, we're careening toward the end of the presentation part of today's session, and we'll go into Q&A soon. So if you have any questions, please pass them up. As we finish up, one thing I want to ask that's a curiosity to me is of you, Steve. You wear a bunch of hats, and it's not just because you have to cover the head that looks like mine. But
My dermatologist tells me that every day.
But how, in terms of the intersection of various participants, how do you think about the philanthropic hat that you wear?
Yeah, no, I think it's an important conversation. It's so great to see at SOCAP that there's a whole, part of this conversation around the role of philanthropy to catalyze these kind of investments. Because I'm pretty convinced as we look forward in the next decade, the real trick here to unlock private capital into healthcare globally will be where both private capital and commercial investment and philanthropic investment go side to side. And you've just heard a couple of examples from my two colleagues around where the Gates Foundation itself was an early investor either in a company or in a process, in part because we sit on a very large balance sheet, so we have a mechanism to make loans and equity investments into some of these companies, but we also have programmatic dollars that we use to try to de-risk some of these investments. And I think the real trick with philanthropic capital over and over, and many of you in the room here are experts at these sort of blended finance mechanisms, but to create the capacity to take some of the risk out of really great innovations that can do very well in a lower middle income country, but that just the risk tolerance is too high or too low, I guess. And so if we can do things either, first stop loss, we've done some guarantees, we've put together, places where we think we can get the clinical trial process to speed it up. And those are the kinds of things that then, will lower the risk issues for a commercial investor. So the large story here is I spend most of my day job thinking about how do we unlock more global philanthropic capital to improve global health and development. And then, but I don't think that's at all unrelated to this night job of helping III, because they're so interlocked more and more. And I think that you'll see that trend even grow in the next decade.
Okay, let's turn to Q&A, but it will sound like the rest of the presentation. We have a question about healthcare workforce development. I think it's mostly for you, Liat, because Grand Challenges takes a multi-sectoral, multidisciplinary approach. You all have talked about technology dispersion as a means of having that impact. I think about the CHIPS Act, and we passed the CHIPS Act and then realized, wait, we don't have engineers. Is that in low and middle income countries, that undoubtedly is an issue. Have you made investments or thought about how to bring workforce along with the technologies that are being put together?
Okay, I'm trying to think how to answer that question. So, one of the areas where we do a number of investments is in primary healthcare and organizations with community health worker models, if we're talking about the labor force, that are trying to provide real sources of income for community health workers. If you're looking at those types of models, there's one example, Healthy Entrepreneurs. It's an organization we funded to expand their model in Uganda and DRC, and now they're in 7 countries and quickly expanding with government support because of the the income generation component that they're providing to community health workers beyond the health impacts that they're providing. What's interesting is when I was at UNGA a few weeks ago, there was one session on community health worker. I'm sort of going on a tangent, but bear with me. That we're talking about, well, in some of these situations where there is increased income from community health care workers, which are usually roles for women when they're volunteer, they're being taken over by men because they're so lucrative. And it's an unforeseen issue that funders and entrepreneurs and did not foresee. So this is one area. I mean, we obviously see the importance and the value of supporting primary health care. We're looking, and these types of models are really key. I hope I answered your question somewhat, but happy to speak to the person who put that question down and would pass it on to others.
We've got great questions, too many to answer here, so I encourage those where we don't get to them to come up and ask them one-on-one. I think they deserve an exposure. So let me ask you, Scarlett, if you could speak to that. Sorry, if you can speak to that also. And at the same time, could you speak to a question we have about the interconnection of climate and healthcare? Do you find yourself investing in solutions, well, you can jump into, in solutions that are for climate resilience that relate to populations' healthcare as well?
Sure, definitely. So on the healthcare worker question, so in the US, by 2026, we are going to have around 6 million healthcare practitioners exit the workforce. And we're going to have nearly 2 million enter into the workforce. We're facing a very serious shortage here. And this is not just about the US, it's actually across the globe. So from us, we think about how do we use technology to actually create impact, because we have a very clear focus on what we can do for the healthcare workers. I'll just give you a very quick example. We have invested in an AI company from Canada that has created an app for healthcare practitioners. Now we have over 800,000 healthcare practitioners. The platform has actually grown 6 times since we invested, and it was only last year, less than, I think, about 14 months ago that we invested in this company. And out of the 800,000 healthcare workers, when we look at the top 10 countries of where these doctors are, most of them are actually low and middle income countries, like India, for example. And this is where digital technologies can actually fill that gap, and in a way that can be delivered digitally and also is very scalable. So that's the kind of things that we look at that can create that kind of impact. Now,
do you want to talk about the climate question, or do you feel put on the spot?
I really want to pass this to Leah to talk about, because she's very well positioned.
I mean, there's no way you can't be investing in health and not be thinking about climate. So, I mean, again, we're part of a Grand Challenges network that started by the Bill and Melinda Gates Foundation, and part of a network with, I don't even know how many we are, I don't know if you know, Steve, but everywhere from Grand Challenges India, Grand Challenge South Africa, Grand Challenges Rwanda, Grand Challenges Brazil. We're a huge network of organizations that are actually coming together, and many are coming to launch our first Grand Challenge in climate, and we're doing essentially the research and information gathering stage right now with partners in many of these countries to determine where, as a Grand Challenges network, we can play that role. I mean, I already gave a couple of examples of organizations that we're funding that are thinking about climate and integrating new aspects, innovation into their work. So it's evolving so much, and we're really learning from our partners especially within the Grand Challenges Network. So for us, it's a new place, but there's no way to avoid it in a way. It's where we're headed. And our funders, Government of Canada, are obviously very supportive.
Yeah, and I just really quickly add, both from the Gates Foundation perspective and from III, there is no air between now the way we think of healthcare and climate. I mean, that it's just that there's, and particularly with our focus on the most disadvantaged, lower middle income country, vulnerable populations, this is where the impact is going to be at its greatest, but it's also where the innovation on both fronts can be have its highest impact. You know, the shifting of health, I mean, on the workforce as well, to shift to, you know, task shifting so more things can be done directly by the patient. Things like that are really important solution spaces, and they're more applicable in lower middle income countries.
Okay, last question that I'm going to ask, and I'm going to just tell the other two questions so that you can come racing up to learn our speakers' answers to them. One question that was asked was, the U.S. or developed countries have some of the same public health issues that have been alluded to here, and solutions would seem to be applicable to them too. Are there lessons from experience in what's being done for lower and middle income countries that can be applied to the needs of especially the poorest parts of the developed world? Who wants to take that?
Well, I'll start. The answer is absolutely. I mean, we've talked for years about what sometimes is called the boomerang effect, or, you know, innovation flowing two ways. And I think there are two things or three things we see more often, and I can give you a couple examples, but where, and you mentioned some already, but where we have the big difference between often the places we do a lot of work in, when I was at Gates or when I was running PATH, is that you've got a different payer model, and the multi-payer model of the U.S. creates some challenges in the way that these things come back and who's going to pay for it. But we see, you know, like community care clinic models that work very well in lower middle income countries, and now we're actually the company I used to run, PATH, has actually started a domestic program to bring some of those lessons back and work with government systems to come back. They're very much low cost innovations, you know, like for birthing care that are being often jerry-rigged in rural clinics in Africa. We've actually adapted them in a more meaningful ways, and now we're seeing those tools come back to the U.S. because they're lower cost, they're very effective, they're very easy to use. So, and that can be on birthing care, it can be on maternal or early maternal care in terms of feeding tools. So that a number of these things are actually finding themselves into U.S. markets. So I think the answer is unequivocal. We'll see more of it.
Okay. So the last two questions that you should come up and ask or listen to. One is presumably for you, but tough question. Doesn't demand a 10x return rule out many companies that could have had impact, but only 4 or 5 times return? So it's, I mean, the question is obviously yes, but how do you think about it? How do you put that? What's a framework for thinking about things that get financed this way or some other way? So I'll leave that for a discussion up here at the front afterwards. And the last one is clearly for Steve. Could you define lives improved or lives impacted? And what metrics do you measure besides that? And how ad hoc are they between different companies in the portfolios? I think we'll save it for, because we're really tight on time now. But just to wrap up, I want to ask each of you very briefly to share what your call to action would be for global health solutions and improvements. And I'll give you a second to think about that while I wrap up with what we've heard here. We've heard lots of use cases and case studies, and that's very exciting to think about how many different ways healthcare can be and public health solutions can be impactful. We've heard about the high profitability of many of them, that this idea of trade-off is not, if properly framed, is not really that relevant. I think it was interesting to hear that non-economic measurement enters into this, and up front we'll hear from Steve to explain what that exactly means. And I enjoyed hearing, being in the private sector, hearing about a government role, and a very complicated government role in catalyzing some of this, and then hearing the term that someone said of last mile delivery, because clearly there's some areas where governments or big philanthropies can't do that last mile delivery. How do you get that? Maybe that's only in a small private fund. So I just wanted to share that. Now let's turn to call to action. Who wants to go first?
I have to. So I would ask two things. Tell us, here at SOCAP particularly, how to get involved if you want III. Well, three things. One, what do you feel as an investor or maybe as a product innovator, what you think philanthropists could do more to help you? And what could governments do more to help you? So we want to inform both the philanthropic and government communities how to help you all be more successful and get more money into this space.
Okay. I mean, I think the call for action for us as we're finalizing our next strategic plan is to take more risks. I mean, we're an innovation funder, and we've just completed a risk assessment and come to the conclusion that we're not taking enough risks, and we're the ones that should be doing it. And I think it will be reflected in our next strategic plan. So I think we all know the real and perceived risks in impact investing. We know how they're heightened when we're talking about global health and emerging markets. And so for us, and I'm sure others in the room, that ability, if we have it, to take more risks, given where I sit relative to Scarlett, for example, is really important going forward. So that would be mine.
Yeah, I have three things to say. So number one, so this is really for founders. So number one, healthcare is really, really hard, and it takes forever. Healthcare adoption takes forever. So even from clinical outcome to actual adoption, meaning getting to the guidelines, clinical guidelines, that time frame, 17, 18 years. It takes that long. So you have to have the patience and the willpower for that. Second thing that I want to say is that within healthcare, we're dealing with so many legacy systems, legacy infrastructure, where you might have a brilliant idea, but it might not be doable because we don't have the underlying platform, the underlying data interoperability, the connectivity. So this is something that people sometimes forget, and I think that we need to be investing hugely into this layer so that all the innovations, technologies that can be built on top of that can flourish. And then the last thing that I want to say is the focus on business model is supremely important within healthcare, because there are 5 different stakeholders in here. You get pharma, medtech, providers, payers, you have governments, and you have the patient sitting in the middle. But the patient is very often not the payer. Most of the time, the patient is not the payer. So how do you find a business model that works? And by the way, be very smart about getting capital, right? You have heard from, so we are a VC. By the way, 10x is not a measure, it's not a requirement. It's actually more to say that we need to see that there is a big business here, which means that because the fact that you have a big business means you can actually create big impact. That's actually what it actually means. But be smart about where you can actually get capital, because whether you are non-for-profit or for-profit, whether you can get concessionary capital, blended finance, all the way to VC, PE, this is all part of the landscape. So seek all kinds of help from everybody. And there's enough capital that's out there to really support different initiatives. So it's really important to tie all that together.